So this is basically a pretty much unchanged presentation I gave at a thing in Auckland about a month ago, which was a Pacific parental mental health seminar. So you can go to sleep if you need to. And so one of the reasons for the title, O Tina Taumawhai, is because just even the word mental health just makes people not interested. And so it basically means it's not quite the struggling mother, but the mother who keeps going through adversities. So it's sort of like struggling but keeping going is what it sort of means. And when I was talking before about pamphlets and things, Amiel brought me up the one that she designed, credit where it's due. It's a little tiny one, so people wouldn't have sort of great big pieces of paper, so it's wallet sized, and at the front it has basically unhappy, but in 7 different Pacific languages, and it had quite extensive sort of, trials with the community, and they definitely didn't want depression or anxiety, but unhappy was the word that they were happy with. And it's really sort of a discussion tool rather than a diagnosis or anything like that. So I'll leave that up here so people can look at it or get hold of Amiel if they want any more information about it. So I'm going to talk, that's what I'm sort of going to talk about. So how big is the problem? Mental health problems in our Pacific people. The darker colour is Pacific. The 2006 study Te Reo Hinengaro, which looked at mental health issues, not schizophrenia, but anxiety, depression, other mood and anxiety disorders, in the general population, oversampled for Māori and Pacific, just so that it would be statistically significant. And what was found was that Pacific people have higher rates of mental disorder than the general population. And they seek help at lower rates. The other thing that was found, which I haven't put on here, is that the longer you've been in New Zealand, the worse it is for your mental health. If you came to New Zealand after the age of 18, you actually have lower rates of anxiety and depression, but if you were born in New Zealand or came before you were 18, particularly before you were 12, then you've got higher rates. And New Zealand-born Pacific people have anxiety depression rates of about 48%, which is about half. So with regard to postnatal depression, as we know, often our Pacific women have fairly high fertility rates. And if you're looking at them also having higher rates of anxiety and depression, one might think that there'd be high rates of postnatal depression. The Pacific Island Family Study asked, that they used the EPDS as in asking the questions, and they also had it translated into the languages but didn't validate it, and found increased rates in Pacific women generally, with alarming rates in Tongan women of 30% and very low rates in Samoan women of 7.6%, which just didn't make sense, because I would have thought that if anything it would be the other way round, but it wasn't. So the methodological flaws were mainly the not having the translated EPDSs validated, and also asking the questions rather than giving them. But they did find behavioural problems in children of depressed women at 2 years old, and they're still finding things about that. So back in 2010, I spent the summer driving around South Auckland, visiting people and asking them lots of really nosy questions. My colleague did the Tongan women and I did the Samoan women, and it's statistically significant. There was 85 of each, but the rates looked similar at around 28%, and that was by EPDS and by clinical interview. But only one of 170 women, of whom 28% were clearly depressed, was under mental health services, and she was actively suicidal. But wasn't on any medication. And it was actually tragic, the suffering that these women were going through. They were really open, and many thanked me for the semi-structured interview, which was just a semi-structured interview, but they seemed to find it useful to actually talk about it. Interestingly, the family was cited as the main reasons for distress, as well as the main reasons for support. And that's borne out by other studies. Like there's a UK study about different ethnic minorities who tend to find family. Yes, they're the main cause of my problems, but they're also my main support. So that's sort of interesting. Can't get rid of family. So with the impacts on children, and this isn't just in Pacific, although the 2-year-old ones have been followed up by the PIF study. We're also looking at emotional and cognitive problems at age 7, impaired academic performance at age 16, increased depression, particularly amongst girls, also at 16, and these changes in cortisol levels amongst adults that I mentioned before. And social adversity also has these effects on kids, although interestingly, boys who are raised in below the poverty line actually have better physical development. So I don't know what that's about, but that was a finding. So if we're looking at the interaction between maternal depression and poverty, unfortunately, many of our Pacific kids are going to fall in that group, so quite profound effects. And we're also, I guess, looking at there being a huge stigma about mental anything. The word in Samoan for, like the sort of general word that people would use is a word called vale, which means stupid, as well as crazy, as well as intellectually impaired, means a lot of different things. And there's sort of no real polite way to talk about mental illness, because you say mental, forget it. And so that's what we've been working around at Taha, mainly Amio's been working around this, is sort of finding ways that we can bring it up and talk about people just switching off. And when I was in Samoa, I was invited to give a 2-day seminar on postnatal depression in 2007. And looking back on it, it was an ill thought out scheme, but I thought, yay, free holiday, lie in the sun, lovely. It became a political hot potato. It was boycotted by politicians. It was really, really difficult. And because the idea was that in Samoa you don't, that's a palangi thing. We don't have that. It's, you weak palangis that do that. But there is a thing called whailelengau, which literally means broken new mother, which contains a whole lot of symptoms which could also be attributable to postnatal depression. And when I started talking about that, that's what I was talking about. Oh, okay. And it was fine suddenly for me to be talking about whailelengau. And also when I was actually trying to stretch all this out into 2 days, I ended up talking about it very biologically, which was much more acceptable than talking about psychosocial stresses, because it was just something that happened in your brain as opposed to in your mind, and the words are different in Samoan, brain and mind, they are different. And so it became something that wasn't your fault for being weak. It was just something that happened with hormonal changes. And people ended up saying, do you have to have just had a baby to have these symptoms? Do you actually have to even be female to just have these symptoms? So it actually brought up a whole lot more around mental health issues anyway. So that was pretty cool. So there are a number of just different Pacific beliefs around childbirth and pregnancy. In Samoa, you're not allowed to be alone when you're pregnant because of aitu or ghosts and spirits. And interestingly, some of the eating prohibitions very much go along with the listeria guidelines, as they do in Tonga. And in Tonga, the postpartum condition is something called kita, which is, again, a good way to discuss the postnatal depression symptoms without using those words. Similarly, there is a condition in the Cooks, but my informant couldn't tell me what it was called. But there is something which you're allowed to have, and doesn't mean that you need to be ashamed about it. So, in the Pacific, when you're treating or looking after a Pacific woman, you need to have her family on board. Balangi women, over 90% will value the advice of their health professional most during their pregnancy. It's exactly opposite amongst Pacific and Māori women. Most of them will value their older female relatives' advice above yours. So if you want them on board with a course of action, you need to get generally their mum on board as well. There's also quite a lot of conflict sometimes between traditional values and research-based advice, and the big one is the bed sharing, because we know that it increases the rates of sudden infant death, but it's an entirely appropriate thing to share your bed with your baby. And of course, if you are lying on a mat in a whale with just a light sheet over you and it's lovely warm weather, that probably is okay, but in a bed in a nasty, damp, cold, horrible environment with lots of covers isn't so good for babies. So finding a way to sort of, I guess, have best practice which doesn't, I guess, negate cultural values, it's a tricky one. Okay, so when I was embarking on this talk in Samoa, I foolishly possibly had a look at the infanticide rates because I'd been asked to go and have a talk with the equivalent of the Justice Minister. And I worked out that if the rates in Samoa were the same as the rates here, which aren't particularly low anyway, you'd expect one infanticide every 37 years in Samoa. 1 or 2 are reported pretty much every year in the national newspaper. So there's something going on. I've said virginity highly prized because it seems that possibly a number of these are related to concealed pregnancies, and of course with the clothes that you wear and the general sort of body habitus, it can be not that difficult to conceal a pregnancy because you can be up for punishment, ostracism, lots of other things if you aren't going along with the desirable so-called norms. And unfortunately some of the babies the neonaticides that we find here are also probably because of that shame stuff. As I've said, suicide is the highest single cause of maternal death in New Zealand. Luckily, it's not very common, so we haven't got comparative rates in different ethnicities, but nevertheless, it's there. And I've said the rates in the islands of maternal deaths due to suicide are grossly underreported. I actually had the guy who collects the statistics in Fiji say, oh, well, they just wouldn't count that. They'd find another cause for it, like accident, because the donors don't like it if people commit suicide. But some of the individual sort of stories that I've heard about really, really unwell women in the islands just really not having treatment. Like in the Solomons, for instance, there's, I think there's population of about 4 million, one psychiatric hospital on one island, and that's all. And I haven't been to that hospital, but I know the one in Fiji, which is relatively, I guess it's been brightened up a bit, is like Carrington in the old days, as is the one in Tonga, which is actually really quite flash, but it's completely full because people live there and keeps sort of getting filled up. So I've completely gone off track about psychiatry generally in the islands anyway. So at the moment we have just the state of play with regard to Pacific maternal mental health. We have specialist teams but not specialist Pacific parental teams. So we have specialist Pacific teams, specialist maternal mental health teams. And community initiatives which one would hope would actually, give a lot of support. It's really not sexy to do mental health because it's still so stigmatised. There are some NGOs which say they do maternal mental health, but actually talking to them, they don't. I think it's possibly because, who was it mentioned, that there's a bit more funding around. Maybe it's because of that. So as I mentioned before, the engagement of Pacific women with the existing services really does seem to be poor. Possibly they're referred at really low rates. The psychiatrist in Samoa said to me, you just can't tell if someone's depressed because they just keep smiling at you, as indeed they will. But if you look when you're not interacting, like look when you're weighing the baby or something like that, and see what happens to the face. The other thing to be aware of is that often Pacific people will smile when they're talking about something that's really distressing. And that's just that's just a culturally appropriate way of doing things. And unfortunately, we know from the Invercargill incident that it can be really difficult to make cross-cultural assessments anyway of mental state, because there are just different ways that people do things. So having a really low threshold of suspicion, I think, is important. And the services that are offered can be experienced as irrelevant, unhelpful, or even punitive, being accused of having mental illness. So where to? As I said before several times, interventions do need to include the family. And some of the interventions may be challenging. The particular one I'm thinking of there is childhood discipline. Whereas, and again I speak mostly about Samoa, where you're actually seen as not loving your child if you don't hit them, because hitting them is the way of ensuring that their soul has eternal life. And there's, I don't know, I've got the, that Bible verse there basically says, don't neglect teaching the children. If you hit them with a stick, they won't die, but if you hit them with a stick, their soul will have eternal life. And then I followed that up with a picture of a dead baby who had been hit by a stick, but I haven't done that for today's thing. And so talking about the importance of not using physical discipline on children can be really difficult, because you're not only going, you're mostly going against the particular brand of Victorian evangelical Christianity that really took hold in the islands, which has now become a traditional part of Pacific cultures, and the mixture is, literally lethal. But again, this gets me onto my whole sort of colonialism thing, which we don't need to talk about here. Okay, so what are we doing about it? The incorporation of emotional well-being in antenatal education, and there is a really, really good website called Tapuaki, which again I keep referring to my friend out the back there, but she sort of designed it and test drove it. It's actually really cool. You press the button and it translates it into 4 different Pacific languages, and it just has the emotional well-being along with all the other things, and it's just really, really cool. Yeah. Yep, we'll put that up there. Yeah. And also there's a whole sort of education of, antenatal education package that's being put together for Pacific women, because often they don't turn up to antenatal classes, appointments, let alone classes. And so that's something which is being piloted in Auckland, and I think is being rolled out through the country now. So that's cool. The other ongoing thing is destigmatisation of mental health, talking about emotional well-being rather than mental health. And as always, developing our Pacific workforce. That's health. And it's actually a Fijian sunrise, not a Samoan sunset. So any questions? So that was just like a real bitty run through there. But I guess we'll probably, the study hasn't been done because the study hasn't been funded, looking at possible risk factors. But some of my thoughts are like just the general increased risk for depression, anxiety amongst Pacific people in New Zealand is this real sort of cultural dissonance between the ideal cultural values, which is collective, it's about family comes first, it's not individual, it's about the good of the family. And also, like, I guess even just things such as being assertive, how kids are supposed to be achieving at school, saying, hi, I'm so-and-so and I'm really good at this. You just wouldn't dream of that if you were a Pacific child or teenager. So part of it is just the real dissonance in cultural values, and also around childbirth, just how one lives, because we live here in little individual houses, and it's cold and damp and you've got doors and walls, whereas back in the islands generally you would be living in extended kin groups or villages, so that if you needed a hand, I mean, you would be inundated with aunties, cousins, sisters, grandparents who would all be expecting to help with the baby rather than just doing it by yourself. And so while that can be sometimes an imposition, you actually want to have time with your baby, that's just how it is. And with other immigrant groups as well, because I used to work with refugees, there's a huge difference between what you expect from back home, and even if you don't sort of like think this is what I expect, it sort of is what you expect. And so again, the gap between how you expect it to be and the reality is sort of where depression and anxiety live. We're also looking at huge financial burdens, because I've forgotten the statistics, but I think we're looking at least half of Pacific children being brought up below the poverty line. Where I said at the bottom of one of the slides about reciprocity and obligations, if you've come to New Zealand, it was generally originally because of finding work so that you could send money home for the family. And so even if you're New Zealand born, there'll still often be that. There's a thing in Samoa called a whaalawe, which basically means troublesome thing, which is, so if there's a funeral or a wedding, it's generally funerals, you need to send money back to the islands, or there'll often be sort of similar things here. So there's a lot of drain on your finances as well. So there is the social problems, there's the cultural issues, and there's also what help is available. So I mean, if you go to your health provider and say, I think I've got whaelelingau, go, what? And so generally what you do for that is you would be rested, someone else would look after the baby, you'd been given special food and paid a lot of attention, which sounds like a pretty good idea, but here you'd probably just get on with it. So I think it's a real mixture of issues, and I think it would be just really, really cool to do those interviews, do some qualitative research and look at what comes up, because that thing that Dr Foliaki and I found of that the families were said, this is what protects me, this is why I'm fine. It's also, this is why I'm not feeling so good. And so we both noticed that from our interviews in both Samoan and Tongan women, but it hasn't been researched properly, it's just an impression.
You would argue that you've got somebody who's of your culture and trained to be a health professional. Is there evidence that that is a better way of working with that group necessarily? Or is it more complex than that?
I think it's a lot more complex than that, because it's mostly a matter of the professional being, and I say patient just loosely, feeling comfortable enough to tell the professional what's going on. And so, I mean, someone will look at me and think, old palangi doctor, zip. And then when I start talking, they usually you sort of get this real double, triple take if I'm speaking in Samoan. And then people start talking. So taking the time to allow someone to feel comfortable and recognising that you're going to get one set of answers at the beginning and probably what's really happening more towards the end. Because not talking, turning the gaze downwards is just a way of remaining polite but just disengaging, whereas your teenage Balangi person might just tell you to F off and walk out. And I guess being aware of like the smiling and laughing if something distressing is being talked about, and not seeing that as an indication of either psychosis or not caring. It's just what you do. So that sort of cultural competency, and there are a whole lot of different things in different cultures. And it's really just a matter of knowing that you don't know, being aware of what your own culture is. Because I mean, Brits are very different from North Americans, but from the outside we tend to look look the same, but it can be very different. So knowing where you come from and what you think is sort of normal, even if you haven't thought about it, and then being able to ask around the other cultures, because they do have good cultural competency training in a number of different areas, and then attempting to just suspend judgment and just get to the person where she or they are. And then you'll probably hear what's happening, and then you can sort of decide what to do. But of course, biology is just one truth. I mean, if we're looking really postmodernist, I mean, what's so true about biology? It's just that I've sort of been trained in the Western biomedical model, and I believe in cortisol. But I guess I also believe in Ma'ietu as well. So, and that's often where the difficulty is walking in both worlds. Back in the early days of European expansion into the Pacific, there were these guys called beachcombers who generally sort of took off from the ship and just lived on the beach and sort of became involved with the local people and sort of acted as an intermediary. I often feel like I'm a beachcomber when I'm in the mental health unit, just sort of trying to interpret for the Pacific patients and their families and the mainstream staff, and trying to walk in between.